Hi, Dr. Flowers. How you doing today?
Hello, Dr. Mayo. How are you doing?
I'm doing well. I'm so excited to have you here to share you and your expertise with our audience. Why don't we start by you telling us a little bit about yourself?
Awesome. Well, thanks again for allowing me to be here. I appreciate it. And I'm just happy to be able to share your audience. So, my background, I've been in healthcare for over 25 years. I started off as a nuclear medicine technologist and kind of worked my way up the ranks into administrative roles. And my most recent corporate experience was in patient safety and risk. And that led me to I guess, my quest for health equity and looking into health equity. My research is specifically looking at how healthcare organizations perpetuate health inequities through their organizational practices. And so, yeah,
Okay.
so the corporatization of healthcare, to be more specific, but how that impacts unequal treatment. And so I'm super excited to be here and share with you and your audience, I guess, my thoughts and have a little chat with you.
Well, it's a lot to unpack there. So I am very interested in your research and your medical background from the hospital to corporate patient safety, patient risk to what you're doing now in your research. I would love to hear one, what motivated you to do the research, and two, what did you find?
Yeah. Well, the motivation came from really a personal experience that I had in my corporate position. And there were some things that I saw and things that I went through that I just was not happy with. What's going on? Okay, we're still here.
Yep, I
Okay.
see you. You're there. We got
All right.
you.
Okay. So, why would, healthcare organizations allow things to happen? Why would they treat people a certain way? And so, as I dug into that, that led me to health equity or inequities. And it ran into capitalism, really, is what I found. And so, the way my research went is I got the perspectives of different stakeholders, patients, community workers, physicians, nurses, administrators, to get their perspective on how safe and how equitable healthcare organizations are. And what I found was kind of shocking. It wasn't that everyone knew that healthcare was not equal. They were very aware of that. However, where it differed by race and also by the stakeholder role was how they felt about corporate healthcare practices. And so it differed depending on, if you were an administrator, if you were a physician, it was kind of like, well, healthcare organizations have to make money. So, they have to do what they do. But from a patient perspective, from a community perspective, it was just feeling the brunt of a lot of the inequitable healthcare opportunities, access, outcomes, all of that. And just wondering again, why? Why is that? And it goes back. I've uncovered a lot in my literary review, and it was really difficult going through it because I had to really dig deep into the past of our country, into slavery, and into even why slavery was started. Why, and it all goes back to greed. It all goes back to money, and so that's why our healthcare companies, even though healthcare in the United States is like 20% of our national GDP, which is huge. And in comparison with other wealthy nations, it's very high, but we are still dead last in comparison to wealthy nations as far as healthcare outcomes are concerned, and especially for African American and indigenous populations.
Awesome. And what is GDP?
Oh, the gross domestic product.
Okay,
So I'm
awesome.
not an econ major, so don't get me to explain how it's calculated, but that's, how our money moves in the country.
Yeah, it's so interesting because in oncology or cancer care, it's a problem because people don't have access. So they are not one getting their wellness visits to really get screenings, and then when they're screened and they're diagnosed, are they getting the treatment? Can they afford the treatment? And then as survivors, cancer survivors, as you know, cancer survivors, those numbers are on the rise. But those individuals, do they have access to the proper care? Because survivors require some different things, different screenings compared to the average citizen.
Yeah.
So, what can we really do about this inequity? And before you even answer that, what is inequity, health inequity? Let's
Mhm.
define that for the audience.
Yeah. So, yeah, that's a big thing to define first. And, there's a lot of different thoughts on what would equal healthcare look like. And so, I guess the general definition is that each person, regardless of race or background or wherever you live, has an equal access and opportunity to achieve the same healthcare outcomes as another person of another race in a different zip code. So, how do you measure that? That will go with parity among the race mix up in the population. So, the racial mix up in the population. So, if African Americans are, 10, 15% of the population, they shouldn't be having 3 times the amount of maternal deaths as in comparison to white women. So, if that parity comes, that's when we would see equality in healthcare. That that's the general definition.
Yeah, because if you look at all of the different cancers across the board, uh, African Americans, other minorities are the same or even have a higher incidence of the cancer, but are dying at higher rates. So
Right.
there's something going on there. Same as with maternal health, it really is a problem and an issue. So what else did your research show? What was some of your suggestions? And I want to talk about it from an organizational standpoint, from a community standpoint, from an advocacy standpoint, but we all know it exists. What can we do about it, if anything?
Oh, that is the $1,000,000 question, Dr. Mayo. That's the $1,000,000 question. So, in my research, and I'll try not to get too granular, too nerdy, because I can nerd out on this if you want me to. But what I looked at is a framework. I looked at two different frameworks. I looked at moral disengagement,
Hmm.
uh, which is part of the social cognitive theory, Albert Bandura, and then I also looked at critical race theory, interest conversions. Right. So in this situation, in looking at the two, when there is an interest or a disinterest, however you look at it, you will find that people who are in the majority have an propensity to disengage morally when it is not in their
Hmm.
interest to engage morally. And so, how do we fix that? What is the solution for that? And that's a tough one because of the history of our country. It needs to be, in my opinion, in my recommendations, there needs to be accountability. There needs to be guardrails set in at different levels. So, from that organizational perspective, right? These healthcare corporations are not going to govern themselves. They're corporations. So there needs to be legislation in place that is going to govern them. I love the legislation in New York. They have the Health Equity Impact Assessment that looks at projects and how they are impacting the communities that these hospitals serve. So they have to look at the health equity impact of that. I think that's brilliant. I think that's something that could be scaled across the country. If there's a political appetite for that, I'm not quite sure, but that is one piece. Another piece is also medical training. I think there needs to be more medical training as far as how, as a physician, as a clinician, as a patient facing employee, and even a non patient facing employee, how your work contributes to inequitable healthcare. And I think even just understanding that would help people, or hopefully help people understand how their work can help promote equality in healthcare. And then from the community or patient perspective, there is work that the patient can do as well. And advocacy is one. And I promote self advocacy, and I actually also have a nonprofit that does just that, that helps bring information to the communities, bring information to people to help them advocate for themselves, help them know what the rules are, what the policies are, and also what they can say and should say to their physicians. It's a two-way conversation, and they need to be having those conversations and need to have confidence in those conversations because they're the customer. And so there's kind of just those three areas, but it's really all going to start with legislation that is going to put that accountability in place for organizations to do what they morally should be doing.
Yeah, absolutely. Thank you for those nuggets. And one thing that's coming to me is like the inequities in, oncology clinical trials. Many of these pharmaceutical industries or sponsors, as we call them, have an initiative where it's the diversity, equity, and inclusion in clinical trials because their clinical trials are not diverse in terms of race, in terms of age, in terms of disability, in terms of the LGBTQ community. So there are a lot of inequities there where they're trying to really fill those gaps. And it's important that those gaps are filled because as we are, doing clinical trials with these different compounds, we don't know if they're efficacious or even safe in these populations. And I know there was a new guideline that came out where if sponsors want to run a trial, it is highly recommended, if not mandated by the FDA, that they have a certain percentage of minorities specifically, because we already know in the research that many of these cancers are more prevalent in the minority population. However, they're not included in the clinical trial. So I think there's a lot to be done. And you mentioned it, healthcare professionals having implicit bias training is one, but it's so hard to shift people. And that's what we're talking about. We're talking about people, right? You talk about racism and slavery. It's all people. It's all power. It's so much to do, and it's so hard because in the gap of that are patients, our lives, essentially.
Yes,
And I would
definitely.
love for you to talk about health equity. I think when we think about health equity, we think about race, like, minorities. But can you touch on some um, other populations that can have inequities in healthcare and how that may look?
Yeah, before I do that, I wanted to touch on something that you said about those clinical trials and the inclusion of minoritized and other diverse populations within those clinical trials. And it's a twofold thing. It's access, and then it's trust. So access is one, those populations knowing and bringing those trials to them, having the access to it, but it's also a trust factor. There's a history, we can have a whole conversation about that, but there's a long history of things that have happened in our country, as far as trials are concerned, that have made a minoritized populations not trust these trials. So they don't want to be treated as guinea pigs. And so a lot of people in minority populations are adverse to trials. They're like, I don't want to be part of this. So I just wanted to call that out too. But as far as diverse populations, well, um, there's a lot of diverse diversity. It's not always along race lines. It's along economic lines.
Mhm.
It's along geographical lines. Environmental um, inequities is also a thing, meaning the um, the environment, the quality of the environment of where someone lives. It's not always divided right along race lines. And that economic equality is big too. Geographically, also rural versus suburban versus urban areas, right? That goes into play with access to a lot of things. If I have a certain level of cancer that needs treatment on a regular basis, and I live in rural Wyoming,
Mhm.
even, there might not be as much access for me to have those treatments if I live in Atlanta. And so you have people, that's where medical tourism comes in, where people are traveling to places. Everyone may not have the means to do that. So there's a lot of different lines that you can kind of cut up this diversity thing. And it's not just along racial lines. A lot of the Caucasian community are actually seeing some of these poor outcomes because the majority of them live in rural areas. And there is a large amount of Caucasian Americans that are under economic lines in certain areas of the country and see these poor outcomes because of the way their state may have rejected, Medicare, Medicaid expansion. So it's a lot of different things that can go into health inequities and the poor outcomes that we see.
Yeah, and I want to kind of just say something in terms of diversity and trust and access, for clinical trials. There's a few studies out that shows that a lot of cancer patients were never asked about being in a trial. So they weren't informed. We're not, because we're making assumptions. I guess that's an implicit bias.
Mhm.
Where there was one study with breast cancer patients, I believe it was 80% of them said they would have joined a clinical trial or considered it
Yeah.
if it was offered. So it's not offered. And I also want to touch on these organizations who are trying to diversify clinical trials in oncology and other spaces, but you need to look internally at your employees. Who are the people, right? So you said the whole mistrust about organizations or even healthcare organizations, but who are these individuals in place to really meet people, the community where they are? So are we sending African Americans out to talk to Caucasians? Are we sending Caucasians to talk to African Americans? Are we sending, heterosexuals out to talk to homosexuals? So we have to look at what we're doing internally. And that's why I love the work that you do, because you, I believe, help organizations, with that lens of what are you trying to accomplish, and like, what are you doing internally to really make that a reality. So can you talk a little bit about how you work with organizations in terms of health equity?
Yes, and you brought up a really, really good point about that, and definitely employee makeup is huge in the healthcare field. There's also research and studies that show that patient outcomes are better. They're improved when they are dealing with clinicians and patient care workers that look like them, that they can relate to. And so, yes, indeed, that trust definitely is bolstered when you are with someone you can relate to. And that can go to, different languages,
Mhm.
different, race. Sexuality, all of that definitely comes into play and helps in that healing process, because that's what this is. It's
Yes.
healthcare. It's a healing process, and so you need to trust someone. I'll jump off of that soapbox for a bit, but how we help healthcare organizations. So my company, Maria D. Flowers and Associates, is a healthcare consulting firm. It's full service. We do specialize in patient safety and health equity, and the way we do that is we work with hospitals and healthcare organizations, one, to understand those gaps, right? And a lot of that comes with looking at or making evidence based decisions. So, looking at the data that they currently have
Mhm.
to understand and digging into that data, really getting to the details and understanding where are we now and where do we need to be. What does our service area look like? How are we serving our service area? And we come in there and do that assessment to really tell them this is where you are. And then this is what you can do to help better the outcomes of the populations that you are serving. And that could be anything from quality improvement initiatives, that could
Mhm.
be anything from training, that could be, some different coaching. It could run the gamut. And we do that through partnerships and collaborations with other consulting firms and other companies that can bring in those services to help them. So I look at the health equity thing. It's not just to check the box. It's
Mm.
not something you can just come in and do implicit bias training. Okay, we did implicit bias training last year. Great, everyone's trained. No, no, no. Implicit bias training is something completely different. The health equity piece of it, it's really a journey. It's an organizational transformation, really. And you have to look at it from, I mean, the entire organization. It's not just your patient facing employees, it's also your non patient facing employees, because an incident can occur where someone may feel discriminated against. That can happen in registration, that can
Right.
happen in scheduling. So you want to look at the whole picture in your organization, and how are you serving your patient population to help decrease um, the adverse healthcare outcomes that are happening with them.
Yeah, absolutely. I love that. And I think everyone should have a consultant like you on staff because it's so important. And, what I hear is sustainability. I think a lot of organizations, it's lip service, it is a check the box. However, we're talking about people's lives, their livelihood, especially oncology with,
Yeah.
patients who are diagnosed or dealing with cancer. That's difficult within itself. They don't need to be faced with, racism, inequities, and not feeling included. So it's definitely so important. I would love for you to speak to, because being realistic, I am a healthcare worker. I know there is a huge shortage in healthcare, and health equity inequities may not be top priority, even though it should. But what can individuals do? Because this seems like a heavy lift. What can individuals within the healthcare system who may be, suffering from stress, burnout,
Yeah.
staff shortages, like what are some micro shifts or steps we can take to help really try to mitigate, this issue of health inequity?
Oh, that's big. That's big. That's huge. And I wish I had one solid answer for that. I think if I had that answer for that, like I'd be laying on a beach somewhere right now with a drink. I don't, but that, yeah, that's another $1 million question. Like, how do we do that? There's so much going on with healthcare. And, when I talk about that transformation and organizational transformation, our healthcare system really needs a transformation. The way that our healthcare is structured in the United States leads to the burnout and the
Hmm.
stress that employees feel. And it does trickle down to our patients. And so a lot of times it may not be just the implicit bias, but that burnout and that stress may ignite some of the, or exacerbate some of the implicit biases that people may have, because it's stressful. Patient care is stressful, in any type of role, whether you're a physician, whether you're a nurse, whether you're a medical assistant, or an allied health professional. It is stressful. And because you want to care, most people go into it because they want to help other people. But then you get into it and it's like, woo, this is tough. This is tough. How do I treat each person like an individual, humanize them? But I know I've got 20 others that I've got to see today. I've got to stay on schedule. It's tough. It's really hard. And I think that it could be done. It's done in other countries. We need to look at a whole change um, of our healthcare system, in starting with the communities and what those communities need, and how we can service patients within their community and help treat them there. And then start adding things to the hospital experience. I know there's some new things coming out now because of technology, where there's a lot of in-home care, especially for aging patients. I
Hmm.
think that's very helpful because that allows people to remain at home with their family, and that's more healing than in a hospital or in a facility setting. And that's a great step. So I think technology will help us, but there's a lot of work that needs to be done.
Yeah, no, absolutely. And I think, first step is an awareness.
Yes.
Acknowledge that it exists.
Acknowledgement, acknowledgement. Yeah, because the way our healthcare system is structured right now, even though it's not working, even though it's not successful as far as outcomes are concerned, it's successful as far as money is concerned. And as
Mm,
long as it's successful as far as money is concerned, healthcare organizations will continue to perpetuate these inequities because it's profitable for them. So why
absolutely.
would we heal? Why would we solve when we've got a steady stream of customers coming in. And the sicker that you are, depending on the coverage that you have, I get more money. So why fix it? And unfortunately, that's how, an organization will never admit that's how they look at things, but that's how they look at things.
Yeah, that bottom
Mhm.
line is essential, and it's really a driver. Can you talk about health equity or health inequity in the COVID era? What was uncovered or unveiled with COVID, and where are we now?
Yeah. Oh, COVID. COVID was a fun time. That's my sarcasm, but yeah. So I think what COVID did, it was a, a blessing and a curse in a way. But COVID really just highlighted and emphasized what a lot of people had been screaming from the rooftops trying to say for a long period of time. There was a landmark study that was done, and they just celebrated the 20th anniversary of that this year, unequal treatment that looked at health inequities. So this is 20 years ago. There are some researchers that have been doing research in this area fervently for all this time and have been saying, hey, this is a problem. And, little movements were made. So when COVID happened and we started seeing a lot of people, African American people, Hispanic Americans, people in urban areas being impacted by this. And then with the social justice issues that we were seeing pop up at the same time, it really highlighted, oh, there really is a problem. And so that allowed a lot of movement in some legislation that you see, like the one I mentioned in New York, the Health Equity Impact Assessment, and then also some in CMS payment, repayment opportunities where health equity strategies were embedded into some of those improvement activities. So now hospitals have to come up with some type of health equity strategy, and then it's tied to payment, and then even for joint commission accreditation,
Mhm.
your patient safety goal. Health equity is a patient safety goal now. So I think it helped in a way, but unfortunately, a lot of damage was done for it to shine that light. I'm hoping that right now, where we are, I mean, there's still an issue. The maternal health issue is coming out now, and that's being publicized, and they're getting a lot of dollars into that, so they'll be able to do a lot more research and find a solution for that. I'm just hoping that that political will stay intact as we go into this election season and into next year, and that we will continue to highlight the inequities because it is a political issue,
Oh, yeah,
unfortunately.
for sure.
So yeah.
For sure. So did you say that health equity is a patient safety goal? Is that what you said?
Yes. So I believe was it last year, either 22 or 23, health equity became a national patient safety goal. So health inequities are a patient safety issue. If you think about
Hmm.
it, if I am haphazardly, either implicitly or explicitly discriminating against a patient and something happens to that patient, that's a patient safety issue. And so
Hmm.
patient safety science, and that is what I apply to the solution of health equity. Um, that is it's now a patient safety goal. And so patient hospitals are challenged now with coming up with something to solve for the health inequities that they see within their organizations. So, and again, that's with data. You can do that with your data, looking at your data. Um, there's different ways you can look at that, but looking at your patient safety from a health equity lens can help you dig deeper into that. Why are we seeing this? Okay, we had someone, we have a patient that is, these patients keep falling out in this urgent care center. Why? Well, if we look and we see it's in a certain neighborhood or it's a certain area, then we can start to dig deep and see that there may be some underlying social determinant of health issues that are causing this that may need to be addressed as well, and not just somebody fell, let's clean up this mess.
Yeah, I think that being a patient safety goal, I think organizations should definitely have someone like you, in their Rolodex or on their team. And I also think patients, just in the same vein of advocacy, is asking healthcare professionals, what is your health equity plan? Or did you know that health equity is a patient safety goal? And what are you guys doing around here? So to inquire, because as consumers, of healthcare, we have the right to know. And I thank you so much for sharing that, because I wasn't aware of that. I'm not sure how many of our viewers or listeners are aware of that, but that's very interesting, and I think that's a great conversation starter. Even employees, if you're listening, what are your organization's health equity goals,
Yes.
or objectives? Like, what are they actually doing? So that is amazing. Well, this has been amazing, and I would love for you to finish us off with like anything else that you think we need to know, any actions that we can take, any takeaways from this session, because I have to bring you back because there's still so much more to unpack.
Well, I would definitely love to come back anytime. You need me, you know how to find me. But I'll just leave with this. If you are uh, patient care provider, clinician, nurse, whatever your level is, just remember to keep in mind the humanity of the person that you're treating, regardless of what they look like, what they sound like, how they speak, how they decide to live. Keep in mind that humanity and try your best, even on those days when you're tired and this is your 15th patient that you've treated for the day, not to treated as not to get so rote in what you're doing and really look at the humanity of that person and try to care for them in that way. And if you are able to speak up for the person, if you see something, see something, say something. If you see something that is wrong that could be contributing to that person's care or lack of care, speak up and say something. And if you are a patient, know that you do have a voice. You have an opportunity to speak. Your appointment time with your physician, and even when you go into a setting where you're having some type of outpatient treatment, that's your opportunity to speak up and talk. So communicate, ask questions, take notes. It's okay to do that. We all have a role to play in getting the equal healthcare treatment that we have. And if you're a corporation and you need assistance with your health equity strategy, you can reach out to me at info@mariadflowers.com. We would love to help.
Thank you so much. This has been such an amazing session. And like I said, we'll definitely have you back. Thank you so much for your time.
Awesome. Thank you.